Thank you, and there were two of us and now there is one. Unfortunately my colleague Dr. Richard McHarg's father has passed away in Scotland, so he has gone back to Scotland, and so all of a sudden it was a bit of a shock to find I'm going to be here on my own. So I'm hoping I'm going to do this justice, and I feel incredibly privileged to be in a room of such motivating people and to be around you all today. So I'm going to share our journey through as one of the first practices in the southern region through our Health Care Home's first year. And for us it was about what happens when you're already a village. So my conflicts of interest, I'm actually born and bred in the Waikato, so I've had a lovely 24 hours reminiscing and going back down memory lane. I've lived more than half of my life in Queenstown now, so consider myself a local. I've been in primary care in the southern region for the last 25 years, and I'm a member of the Southern Clinical Governance Group, along with an advocate for primary care and a huge believer in the nurse practitioner roles. I've also been doing some academic and clinical supervision for the University of Auckland through their training program of nurse practitioners, so you are going to hear a big shout out for nurse practitioners. So I'm just going to take us on a bit of an outline and talk about our journey to this point and moving forward. But I'm hopefully going to put some context around the issues that we faced in Queenstown, and they're all really similar issues to a lot of the practices and the stories we're hearing today, apart from probably one part that's slightly different for us. So just talking about context, many of you in the room, some of you will be too young to remember, our practice was started 50 plus years ago by we call him the god of rural general practice, and that was Dr. Pat Farry, was the founding father of Queenstown Medical Centre, and also a huge advocate for rural primary care in New Zealand. So Queenstown Medical Centre is what we call a collection of homes. So we have 3 practices within the wider Wakatipu Basin, and we're also part of a bigger, what we call village in Queenstown. It's important to understand what our village looks like and how that can change from day to day. And also where we fit within the wider southern region and also within the wider country context. We're part of the Southern DHB, which encompasses everything from Oamaru South, and also part of Well South, which governs the same area or the same district. We have a local hospital, Lakes District Hospital, that has 10 beds and a beautiful $9 million new ED department. And having been in our community hearing of CT scanners first being talked about 20 years ago, we now have one, which is really exciting. Exciting for if you need the CT scanner, because it used to be a now by ambulance through the gorge to Dunstan Hospital for your CT scan. We're 45 minutes helicopter ride from Dunedin Hospital and 2.5 hours by road to Invercargill, or 3.5 hours by road to Dunedin. There's 2 other smaller practices in our community, and we have an enrolled population of around 16,000. Interestingly, the wider Wakatipu Basin resident population is 27,000. So some of those patients are registered with the other practices in our district, but I'll talk about a cohort of patients who actually don't enrol anywhere. We have so 60% of our presentations actually at Queenstown Medical Centre are not enrolled population patients. We have 1.1 million visitors annually to Queenstown Airport, and this is an error. It's a third of all tourism that comes through to the south. Our average daily visitor numbers average around 25,000 a day, and they peak around the 48 to 50,000 mark. So we have just had the Air New Zealand Queenstown Marathon on Saturday, and 30,000 people came to Queenstown for the weekend. So we offer medical services which include a urgent care or an acute facility, which is an accident and medical walk-in facility, plus GP practice, 365 days of the year. So our accident and medical facility is open from 8 till 8, and as I mentioned, we have our local hospital. So I'll just give you a picture of so this is from our new IT system through Well South, which have done a great job, and this is Thalamus. So we have a total population enrolled population at our practice of 16,331. We have a small Māori and Pacific population, 1,645 Asians, and the large group that I'm talking about that don't register or are enrolled with us are our 2,000 plus South American residents who reside in Queenstown, have come to Queenstown on visas when the visa changes happened in 2017 for some of the tourist districts to allow for hospitality workers. So very cleverly, they have come in on a 23-month visa, which actually means they're not entitled to enrol with us. But they are, of course, a really important part of our working community, and they still need medical care. So we have a very, very small cohort of quintile 5, which is really opposite to a lot of other communities, and that quintile 5 equates to around 53 patients in our community. It's interesting, and we always like to argue this one, because what the numbers tell you and what is actually going on in your community is really, really different. Queenstown's one of the most expensive places to live in the country, and we have a large population of New Zealanders who have moved to Queenstown, thinking it is the best place to live and be and raise your family, and invariably have moved away from their significant others or their networks that are around them. And we have a really good habit of doing things in twos. You know, when I went to Queenstown 20-something years ago, we got 2 supermarkets. The next thing that came was 2 casinos. And now we've just got 2 retirement villages. So we seem to do things in twos. So for us at Queenstown Medical Centre, we had a huge problem. And we noticed that this really changed in 2015. Can't quite put our finger on what happened, but our tourist numbers just completely shot through the roof. So we'd started some work before Health Care Homes, knowing that we were mice in a wheel that could not get off. And I've heard the stories from this morning about burnout, and that's where a lot of us were at. And we knew it wasn't sustainable. And we also knew that we needed to focus on our enrolled population because we were being drowned by the tourists that were coming through our facility. We also wanted to streamline the services for our enrolled population, and we also needed to manage or tame the workload that was happening from our visitors and the expectations and the demand. Part of this was also about making sure that we were able to maintain the high quality of healthcare that we believed. And so in 2016, we had a whole staff meeting, 70 of us together in a room. Yes, it's a bit like herding cats, worse than just GPs. But we managed to pull together as a group and decided what was really important to us. And I think probably for me and for a lot of others, really resonated what was our why. Why did I get out of bed in the morning? Why did I turn up day in and day out knowing that I was going to finish the day feeling like a wet fish? Knowing that I would have given my all, but we did. We all went and we all kept doing this. So it was really important to be thinking about burnout, succession planning, keeping and valuing the staff that we had, and how we could work on a strategy or framework to make sure that this happened. So some of the work that went before Health Care Homes. So we've done a whole lot of work around strategy, and we rebranded. So our logo, the depiction down here in the corner, is basically, of course, the International Star or the International Cross of Medicine, along with a pictogram of a snowflake, which talks about what we are in our community. So it's an overlay of that, and the scene behind you've got is a variety of mountains. Now, we were really passionate about our mountains, because the first that came back from the designer were more like hills, and it was like being back in the Waikato, and it was like, well, they're not mountains. They need to be proper mountains. So for us, this was about our connection to the community and celebrating the unique landscape and the environment that we have. And so the colours are the reflection of the seasons that shape our environment, because we do have 4 very distinct seasons in Queenstown. We thought we were good, and we wanted to be great. So this was the message from our staff. They knew that we did a lot of things that were really, really good, but we also knew that we could do better. So there was some work around that we needed to start on. And interestingly, that was when healthcare homes came to the southern region. So we were part of the G4, which sounds really cool. So we were part of the first tranche in the southern region, along with Amity Health, which is a small practice in Dunedin, and along with 2 practices in Gore, big shout out to Gore, Gore Medical and Gore Health. So we had many roadies to Gore, all of us helping in the people mover, off to our training sessions with Well South, taking us through all of the things most of you have done: financial modelling, patient portal, GP triage, telephony and lean process. Every time we left one of those sessions, we would go out of there, and it was a 2-hour ride that went like that because we had so solved the problems of the world. For us though, we were so motivated, we didn't know where to start first. Because every session we left, we wanted to do that first. And oh no, we have to do this first. So for us, it has been one hell of a ride. So interestingly, we did the maturity matrix, and those of us in the lead healthcare homes team decided we actually needed to go away and do this as individuals. So we had an administrator, we had a nurse practitioner, and we had a GP, and we had our CEO do this. And it was very, very interesting where we all thought we were at on this matrix. But it was also an opportunity to realise that there were some things we were actually doing okay in, and also there was a lot of things that we thought actually we're doing okay in, but really, in true reality, we weren't. So year 1 of healthcare homes, like I say, has been one hell of a ride. And one of the things my colleague Rich McHarg talks about, he said, if we're going to tackle this, we actually need to take one humongous bite of the hamburger. He said, we're not going to pick the bun or the beetroot or the lettuce, we're going to pick up the whole thing and take a bite. And we are going to do all of these things. By which stage we're going, really? But we did. So for those of you embarking on the journey, I'm not sure this is right. In hindsight, it was for us the right thing to do. I'm not sure it will be the right thing for a lot of practices. So part of the work we'd started on was about creating team structure, because we'd moved away from a team structure of doctor and nurse who work solely together to pulling our nursing team completely away to become autonomous from our GPs, and we were now in a position we needed to pull things back together and find the good of each model. So we have 4 teams: Tahuna, Pounamu, Remarkables and Arrowtown. Remarkables and Arrowtown are the 2 co-locations of our other practices. We have 4 to 5 doctors and nurse practitioners per team, with 2 to 3 nurses and 1 HCA. So we've started huddles. We've been doing huddles since the beginning of the year, which I think has been one of the bigger things that has been really, really rewarding, because it has actually reconnected us as individuals when you have 70 employees. And so it's been a really, really nice thing for us to do. The rollout of GP triage, love it, love it, love it. And we have surveyed our community who love it, love it, love it. If you think of, we've got lots of young families who have moved into our district who their access to us may only be by boat. And that is if the lake is flat, because if the lake's not flat, they can't get across to us. We have a lot of remote families who live on big stations. So for GP triage for young families or those living on the stations has been incredibly valuable. So we also get very good at connecting with pharmacy about how to get medication back out to them, etc. Patient portal and online bookings is rolling, and we're really excited. We're on the countdown, 2 weeks of open notes, which we thought was going to be a nightmare in our practice, and the hoopla actually hasn't happened. So what we imagined was going to happen actually hasn't happened. Maybe talk to me on the 2nd of December, because I might feel differently. We've leaned out our rooms, and this was incredibly cathartic and incredibly frightening for some of our staff. And I do have to say, namely some of our male GPs who had kind of lived in a bit of abyss in their rooms, and did find it incredibly unsettling. But we are still all friends, and we have got rid of an awful lot of stuff. And we've had an awful lot of laughs, including finding textbooks from Pat Farry's day 50 years ago. So it has been quite a fun process. We've created a lot of offstage spaces because, as you can imagine, as we've been in our building for 20 years now, and when we built that building, or Ngāi Tahu built the building for us below the gondola, we never thought we were going to fill that building. And we have filled and overflown that building. We have a lot of visiting specialists, so room or space is at an absolute premium. So to be able to free up space for clinicians when they need to be offline has been incredibly valuable. We've done surveys in our community. So we've surveyed them on our opening hours to see what they want from us or what they would like from us. We've surveyed them to find out also, and this was incredibly valuable, about how they utilise our service. So is it that they want GP appointments, or is it that they do want to just walk in and be able to see? Is it that they want lunchtime or early morning? So that was incredibly enlightening about what actually our community want from us. SWOT and PEG, and I think probably for me this has been the absolute highlight. So I have not been part of this process, but it has been incredibly powerful. So SWOT, to start with, is led by one of our newer GPs, who is new to our community, and it stands for Staff Workforce Action Team. It's quite powerful. So they don't come out with vests and helmets and guns, but they are a team of our staff. No managers, no leaders are part of that team, and they have created a task manager where any feedback, anything regarding anything in our practice is put. They meet once a month, and they work out how to solve some of these problems before they're taken to our ops team to work out what can be fixed, can be resolved, ways to go around it. The other bit of this is PEG, and PEG is our patient engagement group. So we have just had our second PEG session, and this has been developed by the same GP who leads our SWOT. Pulls together every quarter a group of patients who come to the medical centre between 6 and 8, and it was on Wednesday night last week. We feed them and we hear from them. And for me, having been part of the practice for so long, I don't know why we didn't think about this before. Where have we been? Because the first one that we had, we recruited 40 and we ended up with 30 at the session. Across the lifespan, everyone from the 85-year-old lady to the gentleman who represents Age Concern, who had had a session in a forum with his Age Concern participants before he came, to young mums, to some of the patients who we decided to be part of our PEG were patients who we had received complaints from. So it's a bit like keeping your enemies close. But they provided really, really valuable feedback. And part of that was we then went back to those who couldn't make that session and find out what were the barriers to them coming to the session. And so one of the barriers was for young mums, childcare at that time of night. You know, it's witching hour, it's everything. So we said to them, okay, bring your children. And so we provided babysitters in the practice so that they could attend our PEG session and their children were cared for at the practice. So Wednesday was a real success, and the feedback and the information that we get out of these sessions is incredibly valuable. So it's collated, it goes through to our operations team. Some of that stuff has been implemented, some of it is bigger than big, and so needs to be more of a slower process. But these patients are constantly kept in the loop, and we are constantly recruiting for patients to be part of this group. Healthcare assistants, we've also rolled out. We have 3 healthcare assistants across 4 teams, which will very quickly, we think, become 4, because one of our practices in Arrowtown has grown, and the need is now there probably for another healthcare assistant to be attached to that team on their own. So the things that have enabled us to do this. So as all this was rolling, part of Health Care Homes, the Southern and Primary Community Care Strategy and Action Plan was in play. And this was a document that was produced by the Southern DHB. And when you've been around for as long as I have, you see these things come and go. But this was one of the first real documents we really felt as though we were going to be part of the process and part of the problem solving that needed to take place. So something else that's enabled us in our practice is CLIck. It's our client-led integrated care. I think some areas have a year of care. It's a bit like a long-term conditions program. So based around Flinders, it's a process where patients come in for a 1-hour comprehensive health assessment that's undertaken by a nurse. They are stratified into levels 1, 2 and 3, 0, 1, 2 and 3. 0 and 1 patients are good self-managers who just need a little bit of support. Level 2 patients need a bit more involvement, and of course level 3 are your higher needs patient who need multidisciplinary team meetings, etc. So there's a whole heap of criteria that goes on around this. So the other development for us was around IT. So we had been longing for some kind of integrated IT, and fortunately with Pegasus rolling out Health One and then our DHB picking up, we have Health Connect South and Health One, which will be similar to what you have in the North Island. So it's the primary care talking to secondary care and vice versa. We had willing participants, so we had staff who weren't ready to say, actually, we're out of here, we're done. But they were nearing that. And so they were willing to give it a go, which was great. So, and we had a really supportive and collaborative healthcare homes team. And this wasn't about them not telling us what needed to happen. This was about them saying, these are the things we need to do on this journey. We want to guide, we want to help, we want to support you along the way, but you have to do what is right for your practice. And for us as a practice, that was a real change from other interactions that we've had. We also had a rollout of POACs, and it's interesting, part of my governance role, we're just talking about this because, primary options of acute care, so a lot of the things that are done in general practice actually aren't about acute care. So they're actually about ongoing care. So maybe it's time for a bit of a name change around POACs. And so we have the same POACs that we're hearing from this morning. So the IV fluids, antibiotics, catheterisations, iron infusion, brief intervention mental health services. We have a recent rollout of COPD post-discharge consults and ambulance diversion around our COPD patients. Our team structure has been really very valuable because it's reconnected us internally and also provided our patients with a place to go or a someone to go to in their time of need or when they need to speak to somebody. And the final one is around the top of scope. So it was about our staff, working with our staff to encourage those who wanted to work to their top of scope. So I am one nurse practitioner that is about to be 3, which is really, really exciting. Our HCAs have come along as well and are really embedded in our nursing team. So I'm going to talk a bit more about that because that for us has been a little bit of a struggle. So one of the barriers, and when I don't like calling them barriers because I don't think they are barriers. They're things that we've just had to learn and mould as we've gone on this journey. So it's a movement to migration, and like I said, alluded to earlier, is a lot of people come thinking that it's going to be the place that they're going to settle, and they just find it way too tough. So we have one full-time staff member who is just solely transferring notes in and out of our practice. So we have a large problem, like I said, who come to town thinking they're going to stay, and it's not sustainable. And when I talk about adventure tourism, it's the roll-on impact in our community. So we have a lot of people who not only come as tourists to our community, but a lot of people within our community that take part in some pretty high-risk adventure activities. And we're beautifully co-located below the gondola, which is now Queenstown's mountain biking capital. But that has a massive roll-on effect to the people within our community. So construction, I was working with one construction company over winter, and the poor builder, he had 8 of his builders off all with ski field injuries. So it's that kind of stuff that you're also finding. So when I talk about the IT program rollout, some of the stuff we probably rolled out when things weren't quite right, but that's about getting it rolled out, tweaking it as we go along, and sometimes the tweaks were a little bit slow. I guess the other thing I should add in here, while this is all going on, we decided in our wisdom it was time for a PMS upgrade. No. Please don't put that in your first year of healthcare homes. So I've also got here being as a barrier, being the first in the region to be in the southern. I think it was probably about a bit of nerves and a bit of fear and a bit of trepidation. But would we change it? We wouldn't, because the support that we've had, the collaboration that we've had, the friendships and the professional relationships that we've made have been truly invaluable. So much so now that we just pick up the phone and talk about whatever it is we need to talk about, and which I think in primary care we actually don't have that connection with a lot of practices that we heard this morning. So for us, being a larger practice was a bit of a big one, because we also have, we have 3 locations, and so not all of our staff move around the locations, so the whole communication and keeping everyone on the same page and that consistency was a bit of a challenge. So the rollout of our preventative care program, which was CLIC, was challenging, because foolishly we assumed that GPs have really had a handle on care planning. And not that it's all the GP's job, but it wasn't right. And alongside that, our IT system, so Health Connect South, Health One, the ability to do your care plans in that system at the time was not actually live in our district. It's now live, and I have to say we love it. It's fantastic and has made a huge difference. I think one of the things you need to be prepared for is the mindset change, because for us, that was huge. We were busy doing busy, and we loved doing busy, but it actually was getting us nowhere. We were completely counterproductive. So it was, again, changing our mindset to say, actually, we have to free up this time. So those of us who were healthcare homes lead needed to be able to have that time to really think about it. And I remember doing a session really early on with Hugh Lloyd, who's our GP liaison at the Southern Region. And one of the things was about the time to wonder. And you sometimes have to find the time to wonder. Wonder about whatever it might be, the utopia that you might think is primary care, because we actually don't have that. And I think it's a really valuable thing to be able to do. It's also about realigning the work that's not part of healthcare homes. And for us, that was around the things like occupational medicine, when the workplace safety changes came in. So we were doing a lot of drug testing for patients who didn't even belong to us as a practice. So it's moving that type of stuff, travel medicine, outside of your enrolled populations, and also then staffing that appropriately so that can still take place, but it's not part of your healthcare homes. So our successes, the first thing I have to say is we've actually all survived year 1, and it was incredibly moving and quite emotional to look back at what we've gone through, and we all still like each other. So achieving year 1 was our at-risk targets, and interestingly we didn't achieve one of our at-risk targets initially, and with a lot of work and support, and we managed to get there, which was great. CLIC has finally been a success, which is our preventative, our long-term conditions program. GP triage is absolutely embedded in our practice. All of our GPs and myself do it. We all pretty much have a similar clearance rate. Initially, it was really hard to get everyone's head around it, but once we understood that it was actually about making it better or enabling the patient, our GPs came more on board with it. It was like, well, we've got appointments, so why don't we just see them? So it was changing the mindset around what GP triage was like. Team structure has been, like I said, incredibly valuable and incredibly valuable for our patients. The change management process, so the why. So when we implement a change, it's why are we doing this? And making sure that we prepare our staff and that the staff understand what our why is. The utilisation of POACs has been incredibly worthwhile and has helped our ED presentations, and ED presentations and ASH admissions is one of our year 2 goals, which we're going to work closely with our local hospital on. And I guess the overall, or one of the big successes from us going to healthcare homes is actually being able to manage or tame the beast that has been our acute demand of visitors. So with GP triage, it's enabled us to have those patients that would present, our enrolled patients that used to present to our walk-in clinic, we are now connecting them back with their care provider. So we're connecting them back into their team. So if a patient is GP triaged and they are from my team, Team Punamu, which I'm very proud of, to be Team Greenstone, if they're part of my team, they're triaged back into my team. So they are either seeing me or one of my colleagues in my team rather than being sent into our walk-in clinic, which is full with visitor presentations. So we have made some changes and we've made some improvements, but it was really good to reflect at the end of year one because we actually decided that those things that at the beginning of year one we thought we did really well, actually we could still improve on. So this has been a powerful process of being able to reflect on what we thought was good, but we can actually become to make it great. So the challenge was what would we change? And I've got the HCA role there. I guess we were really fortunate that probably about 8 years ago we had a massive restructure within our nursing team. So we realised that we had a significantly underutilised workforce. So our nurses were utilised at around 30 to 40%, and we knew that they had a lot more in them than that. So we removed from them some not happy about our changes, but all of the clinical administrative tasks that could be done by somebody else. So we had a clinical support team of 3. And so why we found HCA role really challenging is that 2 of those girls have gone into our HCA role. So we had a bit of an overlap of merging roles, and trying to tease that out has been really challenging. Fortunately, we're back on track. It's going to be led by one of our nurse leadership team and our new CEO to get them back on track. So that's going to be a really exciting year. We probably had the worst 3 years of recruitment in our lives. Unfortunately, had gone to market 3 times for a CEO, recruited twice, and due to unforeseen circumstances, neither of those new CEOs could join our practice, which was really sad. But finally, we now have a new CEO, and we have a new nurse leadership team. So we've split the model of leadership. So we have a nurse manager who has a team of 4 nurse leaders who all have a portfolio working really, really closely with our nursing team. One of the things we have struggled with is lean thinking, so our problem solving. So that for us is a really big focus in year 2. And the clinical pharmacy, we are so excited about. So this has been on our radar since we came to Health Care Homes, and we have recruited a clinical pharmacist with Wealth South, who's coming to us from the first week of December in a role of 0.4. The really nice part is that she's engaged to a local Queenstown man, so she's actually going to come and be part of our community. And the biggest thing's probably the communications. Like you've all said, it's nothing new, but it's about the ongoing communications. You know, one of the feedback from our peer group is about the understanding of our team structure. So we did a big shout out to start with, got the message out there, but the message was lost. And I really like that idea of people facing it, you know, video, telling your patients about it. So I'm going home to take some ideas home around how we can keep that communication going. So not only with our patients, but also with our staff and also with our pharmacists, your allied health workers within the community. Really important that we keep those communications going. The big question is, would we do this again? And when we were doing this presentation, we all looked at each other and went, actually, you know what? We wouldn't change, we would. We'd be there in a heartbeat. And I have to say, we're really grateful that we're number 1, 2, 3, 4, because I'm not sure we want to be practice number 69, 70 or 71 that rolls with this. And finally, I just want to acknowledge some really key people. So firstly, to our Queenstown Medical Centre community, to our patients who have embarked on this journey with us. At times it's been fraught, and I think about our recent measles epidemic, which we didn't seem to get a lot of media coverage on, I have to say. Auckland seemed to be getting all the media coverage. But, you know, on that first day that it broke in our community, because unfortunately it started on our ski field and our ski instructor team up there, we fielded 1,300 phone calls about measles. So our staff just about cried. So we had to do some really quick, proactive planning to get it under control. So I'm getting the sign, jeepers. To our Queenstown Medical Centre leaders, or our Health Care Home leaders, Richard McHarg, Anna Highfield, and I do have to say I've done a little bit of work here, along with the wider Queenstown Medical Centre team. They are the rock stars. They're the ones that have embraced this. And to Stuart, Emma and Dan, thank you, Stuart. You've done a great job. From Well South, who are our healthcare homes leaders, they've done a fantastic job. And to the Southern DHB, who have joined us in this. And finally, to the Healthcare Home Collaborative, who have come up with this. We really, really appreciate, sorry, that's my timer, really appreciate that we're on this journey with the rest of you. Thank you.